Welcome to the DIT 2015 Step 1 Review Primer video on immunodeficiencies. Now this lecture by Dr. McGinnis comes from the 2014 Step 1 review, and we've chosen this immunology video because the immunodeficiency disorders are one of the highest yield topics in immunology. You can do very well with these questions if you just focus on the material found in the accompanying study guide. We hope you enjoy the video. It's time for the 3-question warrant for Immunology 9. Let's get going. What defect is associated with the following type of murmur? So if you have a rumbling, late diastolic murmur with an opening snap, that's going to be mitral stenosis. Pansystolic or holosystolic murmur, best heard along the left lower sternal border, generally radiates to the right lower sternal border. This could be either a tricuspid regurg or a VSD. You would need the clinical setting to make a more accurate diagnosis. High-pitched diastolic murmur associated with a widened pulse pressure, that's going to be aortic regurgitation. Aortic regurg has that characteristic widening of the pulse pressure. Crescendo decrescendo systolic murmur heard best at the second or third. Left interspace close to the sternum would be pulmonic stenosis. It's similar in presentation to the aortic stenosis, but just in a different area. Continuous machine-like murmur occurring both in systole and diastole, of course, is going to be the patent ductus arteriosus. Next, which antiarrhythmic has the side effect of synchonism? So you got to think of quinidine. Next question, what stain is required to see the following organism? So if you have Cryptococcus, you're going to use India ink. For PCP, you're going to use a silver stain. And then for chlamydia, you're going to use a Giemsa stain. All right, guys, that's going to be the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about immunodeficiency diseases, which are very high yield for Step 1 and Level 1. Now, this is a 5-star topic. Everyone has at least 2 or 3 questions on immunodeficiencies, but they're usually not too difficult. There are just a handful of things about each disease that you need to know, and I'm going to go through those things for you. You don't need to spend a lot of time digging any deeper than what you're going to find in your Step 1 review book and in the DIT study guide, because that other stuff's not going to be high yield for you. So I'm going to loosely follow the order of these diseases as they're presented in Step Up to Step 1, but we're really going to focus on the material that's in your study guide. So let's start with some B-cell deficiencies. The first one is Bruton agammaglobulinemia, which is number 4 in your study guide. Now this is an X-linked disease, so it's going to be primarily seen in boys. You can use the B in Bruton to remind you that this is found in boys. B for Bruton, B for boys. And also it's a B-cell deficiency. Now specifically, there's a mutation in a tyrosine kinase gene, and that leads to low levels of all the immunoglobulins. This predisposes patients to recurrent bacterial infections after 6 months of age. Now why 6 months? Well, that's when the passive immunity from mom is worn off. Beyond 6 months, there really aren't any IgG and IgA antibodies from mom. The other B-cell deficiency to know about is called a selective immunoglobulin deficiency. So B cells make immunoglobulins, right? So if there's a deficiency of a specific immunoglobulin isotype, that's going to cause problems. Now there are lots of these selective deficiencies, but the only one you need to worry about is the IgA deficiency. So selective IgA deficiency is the most common immunoglobulin deficiency. Now most of these patients appear pretty healthy. They don't even know they have this disease, but what they do have is lots of sinus infections and lung infections. It might be a 30-year-old that has had 3 bouts of pneumonia or who gets sinusitis 3 or 4 times a year. They just think they have bad sinuses, but really it's an IgA deficiency. Now IgA is very important for protecting the sinuses and the airways, and that's going to allow the patient to disable pathogens in the mucus. Now selective IgA deficiency is fairly common. It affects about 1 out of every 600 people of European descent. It's also associated with atopy and asthma. These patients have a lot of allergies and asthma and eczema, that kind of thing. Now, is there anything you can do about this to treat it? Not really. You might have a lower threshold for prescribing antibiotics, but the reason why it's important to diagnose this is that these patients can potentially have anaphylaxis to blood transfusions and blood products. So you definitely need to make this diagnosis ahead of time so that if you need to give a transfusion, you can give something at the same time to prevent that anaphylactic reaction. Next, we're going to talk about some T-cell deficiency disorders. So the first one is thymic aplasia, or DiGeorge syndrome, which is the highest yield of all the T-cell deficiencies. In DiGeorge syndrome, the 3rd and 4th branchial pouches fail to develop embryologically, which means you have no thymus and no parathyroid glands. So because you don't have a thymus, your T cells can't mature, so you have no mature T cells. And then because you have no parathyroids, there's no parathyroid hormone, and that's important for regulating calcium balance. So this results in low calcium, and that leads to tetany. So what signs can you test for that would indicate hypocalcemia? Well, there's Schwastek sign and Trousseau sign. So Schwastek sign is where you tap the patient's cheek and that causes a facial muscle spasm. So you can remember CH for cheek and CH for Schwastek. And then Trousseau sign is where you tighten the blood pressure cuff on the arm for a minute or so, and that leads to carpopedal spasm. So for this one, you can remember T for Trousseau and T for tighten the cuff. Those are your two signs of hypocalcemia. Now, DiGeorge syndrome is also associated with congenital defects of the heart and of the great vessels. And then, of course, because there are no mature T cells, this is going to lead to recurrent viral and fungal and protozoal infections. And about 90% of patients with DiGeorge syndrome have a chromosome 22q11 deletion, and you can detect that with FISH, or fluorescent in situ hybridization. We're going to talk about that test in biochemistry. But again, this deletion is only found about 90% of the time. So most of the time with DiGeorge syndrome, you have this chromosome deletion, but there are some DiGeorge patients that don't have it. So there's definitely a close association, but it's not a one-to-one correlation. Another T cell deficiency is called chronic mucocutaneous candidiasis. Now, there's not really much you have to know about this one. It's a disease of T cell dysfunction, and it specifically causes problems with Candida albicans. So you're going to treat this with ketoconazole so these patients don't get Candida. Then the next one is hyper-IgM syndrome. It's fairly low yield also. With hyper-IgM syndrome, you have lots of IgM antibodies, but decreased amounts of the other immunoglobulins. And there are three different ways this can be inherited. It can be X-linked, where these patients have no CD40 ligand receptors on their T cells. Remember, CD40 was involved in helper T cells helping the B cells to switch from production of IgM to production of other isotypes. And there's also an autosomal recessive type, where the T cells are fine, but the B cells have no CD40. And then there's a third type called Immuno deficiency. That's really all you need to know about hyper-IgM syndrome. Don't get bogged down into any more detail than this. It's probably more than enough already. And the last pure T cell deficiency we have here is IL-12 receptor deficiency. Now, the only thing I want you to know about this is that it causes increased susceptibility to mycobacterial infections. Next, we're going to talk about combined B cell and T cell deficiencies. So the first one is severe combined immunodeficiency, or SCID. This can be caused by a defect in early stem cell differentiation, which can be caused by at least 7 different gene defects. But the only one you need to know for step 1 is the adenosine deaminase deficiency. We're going to see that again when we talk about the purine salvage pathway in biochemistry. We're just touching on it here. But if you don't have B cells and you don't have T cells, the last line of defense with SCID is the natural killer cells. So how does SCID present? Well, the first part of the triad is severe recurrent infections, specifically chronic mucocutaneous candidiasis, fatal or recurrent RSV, or respiratory syncytial virus, VZV, or varicella zoster virus, and herpes simplex virus, measles, flu, or parainfluenza, and then also PCP pneumonia. And then the second part of the triad is chronic diarrhea, and the third part is failure to thrive. So know that triad: recurrent infections, chronic diarrhea, and failure to thrive. Another important feature of SCID is the absence of a thymus. So there's no thymic shadow on the newborn chest x-ray. Definitely be aware of that. In newborns, the thymus is pretty big relative to the chest. The thymus is barely identifiable in adults, but in a newborn you have lots of T cells developing, so the thymus is normally fairly large. Now, in what other disorder would you not expect to see a thymus on the newborn chest x-ray? Well, that's DiGeorge syndrome, because in there, again, the thymus doesn't develop. We called it thymic aplasia. Now, another combined B and T cell deficiency is called Wiskott-Aldrich syndrome. And the mnemonic for this one is WAITER. That stands for Wiskott-Aldrich, immunodeficiency, thrombocytopenia and purpura, eczema, and recurrent pyogenic infections. So if on your test they give you a little boy, because it's X-linked, if they give you a little boy with recurrent infections and he has eczema on his trunk, think about Wiskott-Aldrich. So eczema on the trunk is kind of weird because eczema is usually found in the flexural area, like behind the knees or the flexural part of the elbows or the hands, but not usually on the trunk. So when you see truncal eczema, think about Wiskott-Aldrich syndrome. Then a couple of other important details about Wiskott-Aldrich: that you don't have IgM against the capsular polysaccharides of bacteria. Because of that, you have low IgM levels and high IgA levels. And again, Wiskott-Aldrich is another X-linked disorder. So let's take just a brief sidetrack here for number 12 in your study guide, which asks, what are the X-linked immunodeficiencies? Now, we've mentioned most of these already. A good mnemonic to help you remember these X-linked deficiencies are WACH, or W-A-C-H, which stands for Wiskott-Aldrich, Bruton agamma-globulinemia, chronic granulomatous disease, and I want you to write plus or minus next to that because most of these mutations that cause chronic granulomatous disease are X-linked, but not all of them. I'm going to come back and talk about chronic granulomatous disease in just a minute. And then the H is for hyper-IgM syndrome, which we also said could be X-linked or it could be inherited in other ways. So there are different ways you can group all these diseases in your mind. We're grouping them by what kind of immune cells are affected, but it might also be useful to think about the inheritance patterns. And then our last combined B and T cell deficiency is called ataxia telangiectasia. So ataxia telangiectasia is an IgA deficiency. So remember the A for ataxia and A for IgA. But in addition to the IgA deficiency, there's also a decreased number of T cells. Now, there's a cerebellar ataxia, and then also a poor, smooth pursuit of a moving target with the eyes. So if there's a football going across the visual field or a bird flying by, the patient's going to have a hard time following that with their eyes. It's called poor, smooth pursuit. And then the telangiectasias are seen on the face after age 5. But if possible, you don't want to delay diagnosis until you see those telangiectasias. You want to diagnose this as early as possible because these patients have an increased cancer risk, an increased risk of lymphoma and acute leukemias. So if you see poor, smooth pursuit with the eyes in a toddler, think about ataxia telangiectasia. You don't wait for those telangiectasias to pop up. These patients also have radiation sensitivity because this is a disorder of defective DNA repair. So radiation is going to damage the DNA, and then these patients have a hard time repairing it. So they should avoid X-rays if at all possible. And then AFP, or alpha-fetoprotein, is usually going to be elevated in these kids after 8 months of age. So that can be a useful tool for screening. If you see a toddler with poor, smooth pursuit, you might check the AFP level to screen for ataxia telangiectasia. And that goes back to the A mnemonic. A for ataxia, A for AFP. And then finally, the average age of death is 25. So you want to diagnose this as early as possible. And then our last 4 immunodeficiencies are phagocyte disorders. The first one is chronic granulomatous disease, which is definitely high yield. We mentioned this is usually X-linked, and the underlying defect here is a lack of NADPH oxidase activity, and that results in impotent phagocytes. So your phagocytes go around and they engulf pathogens and debris, and they put that debris and those pathogens into lysosomes. But because these patients don't have NADPH oxidase, their phagocytes can't generate oxygen-free radicals in the lysosome. So they can't kill the pathogens, they can't break them down. So the phagocytes are impotent. Now, because of that, these patients are susceptible to catalase-positive organisms like Staph aureus, E. coli, Klebsiella, Aspergillus, and Candida. But definitely know that deficient enzyme, NADPH oxidase. It's also important to know how we diagnose chronic granulomatous disease. So there's a lab test called a nitroblue tetrazolium dye test, where you add some nitroblue tetrazolium, or NBT, to a sample of the patient's blood. And then normally the phagocytes are going to gobble up this dye, and then the phagocytes that are able to generate oxygen-free radicals will oxidize the dye so that it turns from yellow to a blue-black color. Now on the left side of this drawing, you see what it looks like before the dye has been instilled. And then on the right, the phagocytes have oxidized that NBT to a blue-black pigment. So that's a positive nitroblue tetrazolium test. That's normal. But in chronic granulomatous disease, those impotent phagocytes can't oxidize the NBT, so they don't turn blue. We call that a negative NBT test, and that's how you diagnose chronic granulomatous disease. Then, how do we treat it? Well, we give prophylactic TMP-SMX, or trimethoprim sulfamethoxazole, and also interferon gamma can be helpful in the treatment. Next is Shaydock-Higashi disease. So this involves a defect in the LIST gene, the lysosomal transport gene. And that's important for getting enzymes into the lysosomes. So if you can't get enzymes into the lysosomes, the phagocyte lysosomes are defective, they won't work. So what you're going to see is that these phagocytes engulf things, but they can't do anything with them, so you're going to see giant cytoplasmic granules in the neutrophils. The neutrophil granules are just full of all this stuff that the phagocytes aren't able to break down. And it's worth knowing for the clinical presentation of Shaydock-Higashi disease has this triad of partial albinism, recurrent respiratory tract and skin infections, and a variety of neurologic disorders, everything from peripheral neuropathy to ataxia to seizures. Next is hyperimmunoglobulin E syndrome, or hyper-IgE syndrome. And there's an older name for this, which is Job syndrome, like Job from the Bible. And it's more likely that on your test this is going to be referred to as hyperimmunoglobulin E syndrome. But be aware of both those names. So this is where the patient is deficient in interferon gamma, and that's an important chemotactic signal for neutrophils. So in hyper-IgE syndrome, patients have impaired neutrophil chemotaxis. Now, where does interferon gamma come from? Well, it comes from T cells. So some books and resources are going to classify this as a T cell disorder because it's the T cells that are failing to produce interferon gamma. But the end result is that the phagocytes can't get to where they need to go. And you also have high levels of IgE and eosinophils with this. Now, the clinical triad for hyper IgE syndrome is eczema, so you can remember E for eczema and E for IgE. You can have recurrent cold abscesses, these Staph aureus abscesses. This was first named Job syndrome because these patients were covered with these abscesses, these boils like Job in the Bible. Now, why are these cold abscesses? Well, you have a walled-off area of infection, but the neutrophils can't get there, right? You have impaired neutrophil chemotaxis, so the neutrophils can't get there, and your body's not able to generate an appropriate inflammatory response. So these aren't hot abscesses, these are cold abscesses. These patients also have coarse facial features, such as a broad nose, prominent forehead, which is called frontal bossing. They have deep-set eyes, and they have thick or doughy skin. Then the other interesting thing with Job syndrome is that they can retain their primary teeth, so they have 2 rows of teeth. That's kind of unusual. So if you see that 2 rows of teeth, think about hyper IgE syndrome. And the last disorder we're going to cover is called leukocyte adhesion deficiency syndrome. So the main thing I want you to know about this is that you have abnormal integrins. We talked about integrins in foundations when we talked about leukocyte extravasation. Integrins were the molecules that helped leukocytes exit the circulation and integrate into the interstitium. But with abnormal integrins, phagocytes can't integrate into the interstitium. They can't leave the circulation. And one of the ways that this presents, in addition to recurrent bacterial infections, is delayed separation of the umbilical cord, which is basically a manifestation of impaired wound healing. So if on your test they give you an infant where the umbilical cord is sticking around for a couple of months, think about leukocyte adhesion deficiency syndrome. So that's it for the immunodeficiency states. Very, very high yield stuff overall. But just make sure you know what's in the study guide, and you should be very prepared. Let's go ahead and do the end of session quiz. All right, let's go over the answers. First one, what would you expect to see in a patient with Wiskott-Aldrich syndrome? So remember the mnemonic for Wiskott-Aldrich is waiter. So the first 2 letters, W and A, are for Wiskott and Aldrich. And then you have I for immunodeficiency, T for thrombocytopenia and purpura, E for eczema, and R for recurrent pyogenic infections. Then you can also have deficiency of IgM antibodies and elevated IgA antibodies. Next, what's the cause of chronic granulomatous disease and what infections are these individuals susceptible to? Very high yield question. The cause of chronic granulomatous disease is the absence of NADPH oxidase. So again, those phagocytes can't generate oxygen-free radicals. And that makes these individuals susceptible to catalase-positive pathogens like Staph aureus, E. coli, Klebsiella, Aspergillus, and Candida. And the last question, a young child presents with tetany from hypocalcemia and candidiasis resulting from immunosuppression. What cell type is deficient in this patient? Well, this is DeGeorge syndrome, which is a T cell deficiency from thymic aplasia. And then the hypocalcemia is due to parathyroid gland aplasia. So again, that's DeGeorge syndrome. And then we have a couple of rapid fire facts to go over. The first one is eczema, recurrent cold abscesses, and high serum IgE. Again, that's hyperimmunoglobulin E syndrome, or Job syndrome. And then large lysosomal vesicles in the phagocytes, that's Shida-Higashi disease. And that's it for immunology. I'll see you next time.
These 2 guys don't get along, but when it comes to education, they are never wrong. Yeah, if you pay attention, you might get an A. They don't like each other, but that's okay, 'cause they are bosom buddies.
Hello, and welcome to the show. I'm Dr. Lewis.
And I'm Dr. McInnes. I'm one of the chief educators here at Doctors in Training, and today we're talking about...
Whoa, hold up. I thought I was the chief educator around here.
Yes, that's the title. We're both chief educators.
But look, I've got these awesome glasses and a cool beard.
Me too!
Nice.
Anyway, today we're talking about chronic granulomatous disease.
What'd you say about my grandma?
Not grandma, granulomatous.
Granulomama?
Chronic granulomatous disease is a rare immunodeficiency disorder where the phagocytes are deficient in the enzyme NADPH oxidase. That means they can't generate oxygen-free radicals. So the phagocytes can engulf catalase-positive microbes, but they can't kill them.
Like staph or aspergillus.
Exactly.
There are several diagnostic tests that you can use, but the test that you should remember is called the nitroblue tetrazolium test. Normally, phagocytes will take up the nitroblue tetrazolium and turn it kind of a bluish black color. But phagocytes that lack NADPH oxidase can't do this, so the nitroblue tetrazolium test is negative.
Strong work. You really are a chief educator.
Yeah, I still don't get how there can be two chiefs. What's the saying about too many cooks in the kitchen?
You mean too many cooks spoil the soup?
Soup. What's for lunch?
Never mind. See you next time.